morning, sir. Nice to have you here in 5th MVR CanCon. So I know you are an expert in cutaneous malignancies, and you will be delivering a talk on basal cell carcinoma in the evening. So predominantly we'll be discussing on immunotherapy and cutaneous malignancies today. Sir, our part of the world is not that much having the incidence of melanomas or cutaneous malignancies. So what are your experience and what all risk factors you attribute in the Western world and the stage you are diagnosing melanomas there?
Sure. Yeah. First, thank you for having me here. It's a pleasure to be here with you all today. It's an excellent question. Certainly, we think about skin cancers as having a higher incidence in those of more fair-skinned. But the reality is everyone can be affected by these types of skin cancers, whether it's melanoma, basal cell carcinoma, cutaneous squamous cell carcinoma. The incidence is higher in the western part of the world. In the United States, we see approximately 100,000 new cases of melanoma each year. And there are many million cases of basal cell carcinoma, cutaneous squamous cell carcinoma that we group together in this category of non-melanoma skin cancers. Within the context of melanoma, to answer your question, we in medical oncology often meet people at later stages or higher risk stages. So high risk, I would define as those that are amenable to local therapy, but are at high risk for recurrence, versus advanced disease where it's locally advanced and unresectable or it's already metastatic. So the high risk would be those stage 2, stage 3s that have been resected, the advanced being unresectable stage 3s to stage 4 melanoma. So, we see a lot of those patients in our practice, but we also see some that are even later stage 1 to early stage 2 that are just at higher risk of recurrence.
Okay. So is there any screening programs happening in your part of world for cutaneous malignancies?
Yeah, great question. So I think there's an increasing awareness of this type of malignancy. Melanoma in the United States is one of the few cancers still where the incidence continues to rise over the past decade. Part of this is attributed to improved screening, actually, so we're detecting more cases earlier on. But part of it is also, I think, years of sun damage and tanning bed use and other things are catching up, with the population there. I think there's a lot of efforts, especially on the dermatology side, the public health side, to increase awareness of melanoma and that it's a serious diagnosis. May happens to be Melanoma Awareness Month in the U.S., and so there's a lot of advertising and public outreach that goes on as part of that.
So regarding the surgical aspect, as most microscopic surgery, that is usually routinely we are employed in basal cell carcinoma or in squamous cell carcinoma. So what are your thoughts on its benefit in especially thin melanomas? And do you have any dedicated team in performing the same in your college?
Yeah, good question. Mohs trained dermatologists or surgeons are a really critical part of our team. You're right that they play a special role in basal cell carcinoma and cutaneous squamous cell carcinoma, where there's evidence to suggest that removal of a lesion by Mohs technique, meaning you're looking at the entire margin and making sure every slice and every edge is clear, has shown to have better outcomes than just sort of a wider
margin.
excision. The trick with melanoma is, the standard of care is a little bit different. For in situ lesions, ones that don't penetrate the epidermis, in Mohs surgery, may be utilized in some cases. I think some, risk-benefit discussion there. But the standard of care really for any invasive melanoma is really a wide local excision with 1 to 2 or greater centimeter margin, depending on the depth of penetration.
And as per this last ASCO, we have data on neoadjuvant immune checkpoint inhibitors in NADINA trial. So what are your thoughts on which subset of patients will you consider for this same?
Absolutely. So I think important to understand, the context of the patients that were studied in that trial, and also who this can be applied to as you look at the patient that you're treating in front of you. And NADINA specifically focused on macroscopic stage 3 disease. So this is clinically, palpable lymph node or something detected on a scan. That's different than the patients who may have their sentinel lymph node positivity detected, and they were not showing up with clinically apparent stage 3 disease. So in those with the bulkier disease, in those with clinically apparent stage 3 disease, we have certainly been actually using immunotherapy neoadjuvantly at Johns Hopkins for several years.
So moving on to metastatic settings, we have recommendation for dual immune checkpoint inhibitors as well as single immune checkpoint inhibitors. So which all subset of patients will you consider combining a CTLA4 with a PD-1 anti-PD-1 therapy or LAG3 with a PD-1 therapy, then or versus single agent immunotherapy?
Yeah, excellent question. I think, I can give you some answers based on experience and the data that's out there, but I think the true story is still to be fully written as the data matures even more. Broadly, we look at the risk and benefit of each of these approaches. We know that as we increase, turn up the heat a little bit with each of these approaches, the risk of side effects also goes up. So with single agent anti-PD-1 therapy, we worry about the risk of grade 3 to 4 adverse events being roughly in the range of 10 to 15%. And we know that this may be helpful in producing a response and a meaningful response in 40-45% of patients with melanoma. When we go up to the relatlimab plus nivolumab, anti-PD-1 plus anti-LAG3, we may see that grade 3 or 4 tox rate go up by about 10 to 15%, perhaps around 20 to 25% rate. That rate goes up very high when we use full dose anti-CTLA4 plus anti-PD-1, nivolumab plus ipilimumab, where it's probably much closer to 50 to 60% of patients will have some very serious toxicity. And important to recognize, those can sometimes be life-altering or even life-threatening as well. So I think we have to be very careful. Maybe that patient that's 90 years old that has a lot of comorbidities, they're perhaps a bit more frail. Maybe we would not use anti-CTLA4 plus anti-PD-1, but perhaps that younger patient, or perhaps there we may use either the relatlimab plus nivolumab or single agent anti-PD-1. But in a younger patient that's otherwise fit, they have a good performance status, no other major comorbidities, it would be very reasonable to consider. So I think every decision has to be personalized to the patient that's in front of you.
And we have an alternate dosing schedule also, sir. Usually the FDA approval is for 3 mg nivo ipilimumab plus 1 mg nivolumab. We have other alternative schedule like 3 mg nivo plus 1 mg ipilimumab. That schedule also there.
Yeah, the flip dose, right?
Correct. So moving on, we have a few cases of mucosal melanomas, but from our limited experience, they're all having a poor outcomes. So what are your thoughts on that?
Yeah, I think you're not alone in having the poor outcomes. I think this is a very difficult patient population to treat. We think about mucosal melanomas and acral melanomas actually in people with skin of color. Those are a bit more prominent than your standard cutaneous melanoma. The difficulty is the profile under the microscope and genomically, molecularly looks very different. And we think the reason that skin cancers are so responsive to immunotherapies is they have a high median tumor mutation burden, and they have a lot of signals for the immune system, once it can recognize it, to go and have a really meaningful infiltrative response. With mucosal melanomas, acral melanomas, the tumor mutation burdens are usually lower. The immune system has a more difficult time infiltrating those tumors, recognizing those tumors, and effecting as robust of a response. We may see, for example, with combination ipilimumab and nivolumab, where the response rates are close to 50 or 60% in a superficial spreading or nodular melanoma. They may be as low as 10 or 20% in a mucosal melanoma. It's very critical in those cases to also always evaluate for any actionable mutations. So there are a few things. Even though a BRAF mutation, for example, is less common in a mucosal melanoma, there's about a 10% chance that a c-KIT mutation may be there, and that's something you can target with something like imatinib.
Okay.
So we just want to understand all of the options at our disposal, and then you give it your best shot with the understanding that it's tougher to treat.
So finally, what are your thoughts on PD-1 refractory melanomas? And do we routinely do NGS in your practice for melanoma patients?
Yeah, excellent question. I'll answer the second one first, which is yes, the role that NGS plays is one in informing any actionable mutations, and that might influence your treatment decision making. So any patient that is stage 3 or above is a candidate for adjuvant therapy with targeted therapy, specifically BRAF and MEK inhibitors, or they could receive immunotherapy, right? And so we would get an NGS in all of those patients to understand what all of the options at our disposal are. Stage 2 patients, we may not necessarily do it as standard of care, but if they were to recur, then certainly we would obtain NGS in that setting. You asked an important question about PD-1 refractory melanoma. This is a very evolving landscape. I think we're in cutaneous oncology, about 50% of our patients benefit from first-line immunotherapy, but that leaves a big group of patients that still need something else, or they lose their response to immunotherapy over time. In that setting, we may lean on targeted therapies if that's an option. We may lean on an alternate immunotherapy combination if they didn't have some dose-limiting toxicity from their first regimen. And then the newest kid on the block is, of course, tumor-infiltrating lymphocyte therapy, which was just approved in the United States back in February of 2024. And that showed between about a 30 to 40% response rate in a cohort of melanoma patients that had multiple lines of prior therapy, including BRAF MEK inhibitor therapy plus IO therapy.
Okay, finally, sir, I heard that you're also doing some research on, especially immunotherapy. Can you shed some light on your research activities?
Oh, sure. Yeah, I would be happy to. I think, the reason that we get so excited about skin cancer and cutaneous oncology is many of the seminal advancements in modern immunotherapy have really been born out of the treatment landscape for skin cancers. We have the ability when we treat skin cancers to also collect on-treatment biopsies relatively easier than other cancers. And it's been a very powerful tool to understand what's happening under the surface with the immune system. And a lot of those learnings have been adapted into other cancer types. And it's how immunotherapy is really finding its way into wider use. In my research practice, I spend about half of my time seeing patients and about half of the time in research. It's clinical translational work looking at improving outcomes for patients with high risk and advanced skin cancers. So this primarily involves developing, leading clinical trials in that space for both melanoma and non-melanoma skin cancers. So it's a very gratifying work.
Thank you, sir.
Oh, thank you. Pleasure to be here.